This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. And we're going to take this first segment and do a little update, do a little discussion about what's certainly on top of mind for everyone related to the COVID-19 coronavirus. And, you know, Thomas, each week a lot happens between shows.
Didn't take long to have the top story of the decade, did it?
It really didn't. And, I know when this first broke, there were people that said, hey, is this really that serious? Are we making much ado about nothing? And I think now it's really settled into people. This is a very serious virus. And, we're going to talk to a primary care physician that's going to give us great advice. And I think she's going to rank it on how she thinks it is. But it's really not going to do any good to look back and say, we should have done this, we should have done that. What we really need to focus on is the here and the now. And I think people need to remain calm and have a positive attitude. But even with that, Thomas, I know people are apprehensive. People are concerned. They don't understand the unknown, but we've all got to do our part to help flatten this curve so that the best way to prevent it is for it not to infect anyone.
I know you're sitting in just a plethora of meetings on county level, city level, healthcare level, et cetera. What are some of the main points, the main talking points of what needs to be done now to protect Dallas? You've already said the general theme. We have to flatten the curve.
I think along that same line, to flatten the curve is just to continue to remind people, keep your distancing, don't congregate, practice good health habits. You've got to do these kinds of things. Another thing that you can do as you meet family members, or if you are out, even though you're in groups of less than 10, keep kind of a diary of the people you're with, so that if there is any contagious disease that occurs, you kind of know who you were with, you have a record, and that makes it so much easier when you have to trace it back. I think the other thing that we need to do is we need to do our part related to testing. And by that, I mean, let's don't overwhelm the testing if you really don't need it. We have a lot of virtual sites that have been set up by hospitals where you go through questions, you go through really a virtual screen in many cases, and you come up with, maybe you need to talk with a medical professional. Maybe you need to come in for testing. But let's remember, we don't want to test unnecessarily. We want to preserve tests to do it on the people that truly are at high risk.
We're hearing the news here on KRLD, and we have it coming at us all day long from multiple sources now, so we all know what's going on. This restriction in Dallas that we've experienced so far, the purpose is really that we are trying to step out of ourselves here a little bit and think of the community, right? I mean, why are we being asked not to go to restaurants, not to go to bars? Not that it will help flatten the curve and all that. What happens if we don't? What's the real deal on if we don't do this, then what?
Well, if you don't do it, then you risk more community spread. And if you could risk more community spread, then it's going to prolong this. And we want to end it as soon as possible. And at the same time, not just in Dallas, the folks in Tarrant County, the folks in Collin County, Denton County, and, this week, the governor even issued an executive order related to groups of 10 and also restaurants and bars throughout Texas. So we all have got to do our part, to prevent the spread. But if we don't, we're contributing, unfortunately, to the potential of more community spread, and we don't need that.
We have another big problem. We're going to talk about it in our fourth segment, and that is that a big crisis has developed at Carter BloodCare.
Yeah, absolutely. We're focused on this virus, but Hospitals are here to serve the community. We are the human side of healthcare. Unfortunately, people are still going to have problems with chronic disease. People are going to have cardiac uh, problems. They're going to have things that are going to require medical attention, many of that in an inpatient hospital setting. So we have got to remember that blood is an integral part many times in the treatment of patients. And I think that segment is going to highlight how, even though we're doing the right thing for the coronavirus to stop large groups and gatherings at churches and at other religious places, it has a negative impact on people giving blood.
So Dr. Merlyn Sayers, who is the CEO and president of Carter BloodCare, will be here to tell us of a new appointment-based program, and he'll explain how it works. That will be in our fourth segment, somewhere around 45 minutes past the hour. Be sure to stay tuned for that.
Yeah, that's going to be great. And, Thomas, you just hit on a good point. I think one of the things people can do is, how do I give back to the community? And, if you can give blood, maybe you can't give blood. Maybe there's some medical reason you can't. Volunteer at your food bank. The food banks are doing a good job of keeping people distance, but at the same time, stocking the shelves and working so that we have food in the community. And don't lose sight of the fact that many of our children, not being in school, won't get some of the food they normally get at school. We've got to do the best to help our fellow Texan.
Got about 2 minutes here left. You're a former CFO of hospitals and multi-million-dollar budgets. You want to take a stab at the economic fallout of this?
Well, I'm certainly not an economist, but, I think sometimes there's a lot of dominoes that fall when something like this occurs. As you know, the hospitality industry, the airline industry, a lot of the other transportation industry are going to be negatively impacted. And this actually takes a toll on the workforce too of healthcare. We have to look at our workforce. We want to make sure that they don't get burnt out. At the same time, we want to protect them. I think economically, this is going to have an impact, obviously, for a while. Again, I saw an article the other day where this is going to have more of an impact than 9/11 on the economy, and it's going to have more of an impact than kind of the Great Recession we experienced back around 2007. So I think the real focus now is, how do we help our people? How do we get through this immediate medical crisis? And then how do we move forward so that we can help people that maybe are unemployed or have been furloughed, and we get back on track?
Now, when we come back on the human side of healthcare, we're going to talk to Dr. Madge Barnes. She's a primary care physician in Grand Prairie, and she's going to have some thoughts on how bad this is and how the coronavirus works from a medical perspective.
The conversation with her is just fascinating. She gives us great advice, great food for thought, and is a very positive individual.
So that will be next when we come back on the human side of healthcare on News Radio 1080 KRLD
and radio.com.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back to the human side of healthcare. I'm Steve Love, along with Thomas Miller, and we're delighted that we've got a hospital chief executive officer with us today, Mr. Bob Walker, who's the CEO of Texas Scottish Rite for Children. Bob, thanks for being on the show.
Well, I tell you, excited about being on the show, and thanks, Steve, for the invitation.
A lot of people, Bob, have heard of Texas Scottish Rite Hospital for Children, and I'm sure a lot of people see it when they ride by it, but they may not know the history. Can we go back a little bit and tell us when this hospital actually began and what was its mission?
Sure. I tell you, Steve, it goes back a few years. In fact, this next year will be our centennial year, so it almost goes back 100 years. And its origin started with a breakout of polio in Dallas. It really wasn't just limited to Dallas, it was around the country. But there was a physician in town whose name was W.B. Carroll, and he was the first orthopedist in Dallas. He'd been trained through the military and settled in Dallas after World War I. But he and a group of Masons identified a need for a facility that could take care of children who had been afflicted with polio. And there was a lot in the Dallas area. There was, from what we understand, overcrowded conditions as far as hospitals are concerned. So initially, Dr. Carroll opened had a clinic and allocated a portion of his time at that clinic free of charge to those children who had been diagnosed with polio. And shortly after, the Masons, the Masonic community, recognized the need for an inpatient facility. So in 1921, the hospital was built. So it goes back a number of years ago with really that epidemic of polio is its origin.
And I know the mission of the hospital, and I know it's still true today, is you've never turned a child away. Children that have needed help, regardless of their financial ability or the finances of their parents, you've treated those children.
That's correct, and that goes back to just our beginning. And as Dr. Carroll started his clinic free of charge, that sort of set the tone, so to speak, for Scottish Rite Hospital. So throughout, all these years, we have been able to treat children, and certainly regardless of their ability to pay. For 92 years, we did not charge at all, and it's just been within the last 8 years that we implemented a revenue cycle here at the hospital, which helps supports the mission of the hospital. But still today, no child, and will ever be denied care for the inability to pay. If they have a condition that we can treat and we have the medical expertise for that condition, we want to make sure that that child gets the treatment. We actually have a saying, we never say no to a child. In the event we are so subspecialized in what we do, in the event that a child has a condition that we do not treat, we will make every effort we can through Family Resource Center here at the hospital to direct that patient to the appropriate facility to get care, whether it be locally or somewhere else in the country. But we're truly committed to children and making sure they get the care that they need.
And Bob, I know that you're also a teaching hospital. I know you're affiliated with universities, but you help train physicians and surgeons that when they leave Texas Scottish Rite, they go into the community or potentially other parts of the country and, frankly, I think around the world. Is that correct?
That's right, Steve. Teaching is just a part of our DNA. That's a part of who we are, and we are affiliated with 70 to 80 schools around the country. We are strongly aligned with UT Southwestern here in Dallas, but really in every department that we have some type of affiliation with a teaching program. Every resident over at UT in orthopedics will spend a portion of their time getting their pediatric orthopedic affiliation. In addition to that, we have a program, a fellowship program in pediatric orthopedics, which we accept 5 fellows a year. That's the largest such program in the country. We've been doing that for over 30 years, approaching 35 years. We've trained in excess of 200 fellows. And as you said, you can go into any major metropolitan area and you will find the presence of fellows that have been trained at Scottish Rite in Dallas. So this has been really a tremendous outreach program, and it gives us the ability to have the impact on children's lives well beyond our geographical limits of just sort of the Dallas, North Texas area. But and also you mentioned literally around the world, we do have and have and do have an international fellowship program where we train physicians from other parts of the world and have an impact really globally.
And Bob, we've talked a little bit about your surgeons and physicians, and we think in terms of the children being treated as inpatients, but you also have a large volume of outpatients and outpatient programs. Is that correct?
Yes, I tell you, as over the years in healthcare, a lot of our work has shifted to outpatients, and we still do certainly a number of surgeries here that require inpatient admission, but the treatment of our patients, very similar to the treatment in general in healthcare, has shifted a lot to outpatients. And our volume as far as outpatient surgeries have grown dramatically, and I think this is good in several different ways, but it's better for a child to be at home as opposed to being hospitalized for a long period of time. And when a child can come in and get a surgery and then be followed on an outpatient basis, we feel like that's really better for the child and the family. But we certainly still have a fairly large inpatient volume and do a lot of patients that require inpatient admissions.
And you do some outpatient work not even related to surgery in orthopedics, don't you, as far as any kind of learning disabilities? Do you do some treatment in those areas?
Yeah, I tell you, and that's a pretty interesting story, and it's an area where we diagnose and treat children with dyslexia. And I might just give you a quick history on that. It started in 1965, so that's been a few years ago, over 50 years ago now, that has been a part of the services we provide. But just very quickly, in the early 60s and 50s, up into that point, when a child was having a learning issue in school, it really had not been defined, and the medical community really thought it was more of a stage of development of that child. So, for example, if a child is not reading, at the first or second, third grade, they felt that this child would just grow into that. But we had a pediatric neurologist on staff whose name was Dr. Luke Waits, and his perspective was a little different. He felt there was definitely a medical issue related to that child in many cases, and he started a program. He actually was with the medical school and had done consulting here at the hospital, and he was a pediatric neurologist, those children that had neurological needs. But anyway, he came over in 1965 and set up what is called today the Luke Waits Center of Dyslexia, or for Dyslexia, and was truly one of the pioneers in the entire country in identifying those children with dyslexia. In fact, in 1968, the World Federation of Neurologists met here at Scottish Rite and coined the term dyslexia and defined that. And really, the rest is sort of history. It turned out he was a little bit of an outlier in his thoughts at that time, and true what you might call a pioneer. But it turned out where his theories were right, and it's been helped so many children throughout the years with that. And what we specialize in is dyslexia, which is related to more reading and spelling. But that's how it sort of ended up at Scottish Rite. It has nothing really to do with orthopedics, but it has become a very major part of what we do in service to the community and to school districts. We work with a lot of school districts around the state and have written a curriculum that is used in over 500 school districts throughout the state of Texas.
And we will have a segment in a future show on that dyslexia program, which is renowned in schools nationwide. We have so much more from this wonderful interview that we would love to share, but time prohibits, so you can check it out on our podcast, the full-length interview with Bob Walker, on all your favorite podcast players. Now, when we come back, we're going back to the front lines on the coronavirus with Dr. Madge Barnes, primary care physician, next on the human side of healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
Welcome back to the human side of healthcare. There is a new reality in our world called coronavirus, and understanding and knowledge is indeed power. And we're going to talk to a physician who is on the front lines of this. Dr. Madge Barnes is with Texas Health Family Care in Grand Prairie, which is a Texas Health Physicians Group practice. And one of the biggest questions that many of us are asking is, what is the difference between this and the flu or just bad allergies?
The key symptom that differentiates the coronavirus from the typical influenza, if there's such a thing as a typical influenza, is that you can have the cough, but one important differentiating factor is an increase in respiratory difficulty, respiratory distress. That is not seen in other types of influenza-type viruses. So that helps to differentiate it. Of course, both are associated with fever, but it's the fever along with the respiratory difficulty.
As far as how it spreads, if you have these key symptoms and you've traveled or haven't traveled, what are your thoughts on how it spreads?
Well, the thought initially was that it spread by camels, cattle, cats, and bats. In this instance, it spread from a bat to a human. But only rarely would the animal coronavirus affect the human, but that happened.
Dr. Barnes, in your mind, as we look at the spread of the COVID-19, what would you say are really imperative, necessary steps that we need to take to prevent this spread?
The steps that we need to take, I believe we are now taking, which is social distancing. I think that is very important. Minimizing the number of gatherings of large numbers of people. So, and I hate the word social isolation, but in effect, that's what we're doing. And that should be paramount in the high-risk folks. And those individuals would be, that number, I've seen it change a couple of times. Initially, I've seen 60, but I've also heard 65, anyone over the age. So I would say anyone over the age of 60. They would be considered high risk. Also, anyone with a pre-existing condition, i.e. cardiovascular disease, hypertension, diabetes, immune deficiency disorders, HIV, someone that has recently had cancer and their immune system is suppressed, those folks would be at high risk. And most importantly, let me add, pulmonary diseases or lung diseases, COPD, emphysema, asthma, very high risk. And those are the folks that definitely would need to be isolated, home sheltering if they come in contact with anyone for at least 14 days, 2 to 14 days, because that is the period of time that the virus can replicate and cause disease.
Okay, so let me ask you this, Dr. Barnes. In your experience, we've been through SARS, we've been through MERS, we've been through Legionnaire's disease, H1N1, and now we're certainly dealing with COVID-19. In your opinion, and we don't want our listeners to panic, just the contrary.
Right.
We want people to be at ease and not panic. But how would you rank what we're dealing with now versus, say, H1N1?
I think I was involved with H1N1 back in 2009 as the medical director of the city of Dallas. So I think we're on target at this point. We probably, a little more testing or earlier testing might have been beneficial, but nevertheless, I believe we are having a coordinated effort towards mitigating the effects of the COVID-19. And I'm just glad that all the entities, FEMA, as well as the political World Health Organization and CDC are all on the same page, and we're making a concerted effort towards the eradication. I see that we will turn a corner, and the problem is no one knows where that corner is going to be because this is a new virus, but we can know one thing for sure. In looking at China right now, they're turning the corner. They're not there, and so that would be about a 2 to 3 month period, and now they're turning the corner with decrease in number of cases, and I could see the same for the United States and other countries.
Dr. Barnes, in an extreme move to help prevent this and to flatten the curve, if you will. The county and the city recently, in some of the adjoining counties, have shut down restaurants, bars, and taverns for eating food, in dining, but they have takeout and drive through. Is that something that will help prevent this spread?
Yes, yes, it would. Again, the social distancing, the population most likely that would be attending these events would be the younger population that would be less likely to develop symptoms, although they could very well have COVID-19. But they have parents, they have grandparents. So I do think that they, just as well as everyone else, should need to do social isolation. Or I hate to say that, social distancing. Let me say that. That's a little better way to say it. Because it's a matter of protecting themselves, but more importantly, protecting those around them, because they can carry it and transmit it, but they're fine. But that person that has emphysema or heart disease is not.
Let's go back to your point on the plant-based diet, which we know is just good and healthy anyway. And yet, during these times, food deliveries to grocery stores is becoming more uncertain. How can we do a good plant-based if maybe some of the things we have to do is relegated even to canned goods, etc.?
Frozen vegetables tend to sit in refrigerator and frozen food areas, quite often untouched, and they are probably the next best thing to fresh vegetables is frozen. Yes, we probably would need canned. I mean, nothing is perfect, but at this point, we need vegetables, fruit, plant-based products and foods, and we do the best we can until our symptoms and things improve. But I would definitely still push vegetables, fruit, even if they're canned and even if they're frozen.
As a family physician, you deal with kids, teenagers, young adults, middle-aged adults, older adults. How are you treating and advising your younger patients, even your kids?
I don't see the youngest kids that I see are 10, so I haven't seen a great number of children, but I do see some coming in with their parents, it will be the same message, avoiding your eyes, your nose, your mouth, hand washing, hand sanitizing. It will be the same message, but probably not as anxiety producing, because kids process situations of this nature quite a bit differently, or they don't always have the ability to understand what's going on and might lend themselves towards panic. So really trying to in a calm manner, and usually I use humor, just say, you need to eat vegetables, your mom always told you that. So even more so now, that's important. But just continuing to do what they should already be doing, just washing their hands more and using a little more hand sanitizer and that distance.
As a medical director over a large metropolitan area, as we see these growth curves of the virus, everything looks like a ladder leaning against a wall right now. What does it take community-wide to roll those over and begin a decline?
Well, people staying at home, number one, just really I think the social distancing is very critically important, because at some point the hospital systems, the clinics are not going to be able to fulfill the needs of that population or the population at risk. But also the healthcare, we also have to be quite careful as well to make sure that we stay in a healthy state. So we have to look at options right now. Telemedicine, I think, is one of the biggest options that we have. And I believe telemedicine is something whose time has not only come, but is very critical right now. It keeps folks out of the emergency room. It keeps doctors, healthcare providers safe, because we're not at risk from the potential COVID virus patients. And that's going to keep that curve, give it that slope.
Looks like a lot of things are going to be moving online as a result of this.
And I think it's by design, and I think it needs to be.
So if you sneeze 4 or 5 quick times and you have that little bit of scratchy throat and you go, uh-oh, what are you supposed to do?
Check your temperature. The most common cause this time of year would be allergies, allergic rhinitis. But the key is that you don't have a fever with allergies and allergic rhinitis.
Is it 100% that you do with COVID?
I never like to say 100%, but I'd say it'd be pretty darn close. Yes. But if someone has, say, if they've taken Tylenol or aspirin, then they're not going to register as having a fever. And if they just happen to not tell you that, then you'll say, oh, this person's afebrile. My
understanding, it's a low-grade fever, right?
With the flu itself, it's usually 101. So 100.5 is, I believe, the cutoff for sending someone to have further evaluation. 99, no, that's pretty much normal.
On a scale of 1 to 10 of severity, where would you put this in your opinion?
About a 7.5.
It's pretty serious.
Yeah, it is. And I trust that I just feel it will get a little worse before it gets better, but it will get better. We just don't know when.
Thank you, Dr. Barnes. We appreciate the advice you've given us. And now, Thomas, as we conclude this segment, but we're going to the next segment, there are other issues that come out, not only directly with this virus, but implications down the line. We've got a serious blood shortage.
Whenever there is a community issue or a community disaster, that is always one of the first things that is impacted is the blood supply. Blood is needed in so many different areas of the hospital, especially in surgery. And the thing about it is there's no mercy with this. When you need blood, and it can only come from somebody else.
You're so right, Thomas. And we're going to listen to Dr. Merlyn Sayers here in a few minutes, and he's going to tell us how even with all the obstacles that have come because of this virus, there's a way to still give blood.
A very important and urgent community announcement coming up next on the human side of healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the human side of healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back to the human side of healthcare. As you know, much of the topics that we've been talking about, that you've been reading about, that you've been concerned about, revolve around COVID-19. But there are other things that come out of that impact you, impact healthcare, and impact saving lives. And I'm talking about blood banks, having blood drives. We need that precious commodity, regardless of where you are in your life. Many times when you need blood, it's so important. We could not have a better expert dealing with this subject than Dr. Merlyn Sayers, who's the CEO of Carter Blood Bank. Dr. Sayers, welcome to the show.
Steve, many, many thanks indeed for this.
Dr. Sayers, we'll jump right in on the questions. What have you seen, unfortunately, impacting blood drives and blood donations over the past 6 to 8 weeks?
Steve, here's the issue for us. Carter BloodCare serves something like 200 hospitals in a 50-county area from Waco out to Tyler and then predominantly in Dallas and Fort Worth. At those 200 hospitals, something like 600 people every single day need a blood transfusion. And they don't need just one unit. Some of them need 2, some of them need 20. So Carter BloodCare has to draw in our geographic area something like 1,000 individuals a day who are willing to be altruistic and donate their blood for the support of transfusion-dependent patients. Now, what has happened is this. Something like 50% of all those donations by public-spirited individuals were previously drawn at businesses, at churches and other places of worship, at schools, at colleges and universities. And now, virtually overnight, Steve, our ability to get access to those would-be donors has been closed off. The schools are closed down. Businesses are encouraging people to work at home. There's social distancing. Individuals who were attending their church services or their house of worship services, they have been closed down. So 50% of the blood that we were drawing on those opportunities, sponsors have decided that given the emphasis on protective mechanisms against coronavirus infection, sponsorships have fallen off. So we have lost very dramatically something like 50% of the community's available blood supply. That's our challenge.
That is a big challenge. And as I was listening to you, Dr. Sayers, with some of the county ordinances and city ordinances, which we certainly understand and support because we need to flatten the curve related to this coronavirus, in lieu of schools being closed, many churches and other places of worship doing things virtually, what is the answer related to how people could give blood to Carter BloodCare? Is there an answer or a solution, especially trying to keep distancing?
There is a solution, Steve, and we're so grateful to the Hospital Council for giving us an opportunity to air what that solution is. Carter BloodCare has something like 26 neighborhood locations scattered throughout our 50-county area. And what we're asking individuals to do is go to Carter BloodCare's website, find out where one of their nearby donor locations is, and then phone up and make an appointment. Now, previously, we were able to say, come by, but you made the point, the very valid point, that distancing is important in our need to ensure that we take all the coronavirus prevention methods that we can. So the reason why we're emphasizing now that it's important to make an appointment is that enables us to make sure that the flow of donors through these centers is graduated and individuals are not waiting, perhaps in a small group, for their turn to have questions asked or to actually make the donation. If we can have appointments rather than individuals coming by when they feel that there's a donation center in the neighborhood, if we have them making appointments, we can make sure that that flow of individuals does not offend the very understandable restriction on gathering in tight groups. We know these restrictions have to be adhered to, and it's important for us to take these different steps.
You know, it sounds like you've really thought this through and you've got those 26 locations. But let me ask you this, and I'm asking it because I know people are thinking it. What about people that are fearful about getting blood now from people that donate if they could, in fact, get the coronavirus? Is there any tests you're doing related to the coronavirus?
We are not. And that does not mean at all that we are negligent. What it reflects on is the fact that the coronavirus is not transmitted by transfusion. It's a respiratory virus, and we've had experience with respiratory viruses for decades. Influenza is another one. And there is no shred of evidence that that virus either is transmitted by transfusion. So while there is no test, and we say there does not need to be a test because the virus is not transmitted by transfusion, the other important point is this. We know that the individuals who present to donate are healthy individuals. The very first question in the donor questionnaire is, are you feeling well and healthy? So those individuals who go to the neighborhood centers to donate, they can rest assured that they are mixing with healthy people. And the likelihood that they're going to get infected by the coronavirus because they're blood donors is zero.
You know, that's really good. And for our listeners who may not have caught that, Dr. Sayers made it very clear the blood will be very safe because the coronavirus that we're talking about is not transmitted through blood transfusions. It's very, very similar, as he said, to influenza. You know, Dr. Sayers, I know you have made an all-out appeal, as you should, on behalf of all of us. What question should I have asked you that I haven't, that you are talking to our listeners now? What do you want them to hear specifically about this situation?
I don't want to sound melodramatic, Steve. I really don't. But patients die from the blood they do not get. And when we say that blood is life-saving, we're saying thank you to those individuals who rolled up their sleeves and donated for patients who need a transfusion, patients who cannot wait until this coronavirus epidemic is over. When they need a transfusion, they need it now. They can't wait till when it's convenient for somebody to give. So on behalf of everybody here at Carter BloodCare, I just want to say thank you so sincerely to all those public-spirited individuals, those individuals who recognize the community need, who altruistically give of their time and give of their blood as blood donors.
Excellent way to end this segment. Thank you so much, Dr. Sayers. Thanks for what you do for the community. And to our listeners, please join us next week. We're going to be right back here on KRLD. We're going to continue the discussion of the coronavirus, and we're going to stay abreast of it. So we will keep you informed as warranted. Thank you very much.
And as this story continues to develop, staying informed is the most important thing you can do. We have podcasts of all of our episodes on all the major podcast players. Just search The Human Side of Healthcare. Many of our interviews, like with Bob Walker from Texas Scottish Rite, cannot air the entirety on the show, so that full-length interview is on the podcast. Also, if you would like to reach out to Steve Love or the Dallas-Fort Worth Hospital Council, the email is radio@dfwhc.org. Steve will be on local media as requested and back here next week at 1 o'clock on The Human Side of Healthcare on News Radio 1080 KRLD. Thanks for listening and stay safe.